Hello, I'm Dr. Michael Kohler, and this is Thad, who works as one of Loyola's standardized patients. The purpose of this training video is to introduce first-year medical students to the steps of the lung examination. You'll remember last semester when we did the thorax video, we reviewed surface anatomy, landmarks, and how to orient yourself with the vertical axes around the chest. And I can refer you back to that video, the thorax, for those steps. And again, this video will just concentrate on the actual examination steps of the lung. And of course, before we begin any examination, we always wash our hands. So I'm going to first wash my hands. The first part of the lung examination is to check for the respiratory rate. And of course, to do that, you need to observe the patient's respiratory rate. But if you actually stare at a patient and watch them breathe, they become very self-conscious and anxious, and you'll not get a true representation of their respiratory rate. So what's recommended is that when you're checking the patient's radial pulse, you obviously count for 15 seconds for their pulse, and then keep looking at your watch. Count the number of breaths for 30 seconds. And out of the corner of your eyes or your peripheral vision, watch their chest rise and fall. The patient will obviously think that you're still counting their pulse, and then they won't be self-conscious about you watching for their respiratory rate. Count the number of breaths for a full 30 seconds to 1 minute to determine the respiratory rate. Since the respiratory rate is normally much slower than the pulse, you need to count for a longer period of time to accurately measure the number of breaths per minute. Also, during this time, you'll be watching for the chest wall's expansion. You'll notice that the chest expands symmetrically or not at this point in time. So again, out of your peripheral vision, watch the chest, how it rises and falls. At this point, we'll go ahead and begin the first step of the lung exam, which is inspection. So if I can ask you to turn around to this side, and we'll actually go ahead and open up the gown here to visualize the posterior thorax. Check for symmetry of motion of the right and left chest wall. Also, look for any scars, rashes, or other skin abnormalities that may be on the chest wall. After you've finished inspection, the next part of the examination is palpation of the posterior back and chest wall. Certainly, if the patient complained of tenderness during the history, you would direct your palpation specifically towards that area of tenderness. In general, you want to feel for any abnormalities of the skin and subcutaneous structures. You might notice lipomas or sebaceous cysts as you palpate the posterior chest wall. You don't need to do an extensive palpation if the patient doesn't have any complaints. Next, we'll check for chest wall expansion. Let the patient know you will be placing your hands on their chest wall so as not to surprise or startle them. Place your fingers on the patient's lower thorax and about the mid-axillary line. Then wrap your hands around the chest posteriorly and grab a fold of skin with each thumb as the patient exhales. Let me demonstrate this technique for you. Begin by putting your hands at the bottom of the patient's thorax and grab a fold of skin together. You'll notice as Thad takes a deep inspiration, my thumbs move apart and the skin fold that I gathered minimizes. Notice between each cycle that there's a symmetric movement apart of my thumbs and also a symmetric decrease of that skin fold. If one side does not expand normally, then you think about abnormalities such as a unilateral bronchial obstruction, a lobar pneumonia, or a large pleural effusion. Next, we're going to check for tactile fremitus. You'll remember that tactile fremitus allows the examiner to check for palpable vibrations which are transmitted through the bronchopulmonary tree to the chest wall as the patient speaks. So we'll ask Thad to grab his shoulders. By doing that, the scapula move laterally, and we increase the area of lung fields that we can examine. There's a few different techniques for examining tactile fremitus. Number one, Bates recommends you can use the ball of your hand or the metacarpal phalangeal joints. You could also use the ulnar surface of your hand to check for vibrations. Or finally, you can use the dorsal surface of your fingers to check for vibrations. You're going to do this symmetrically, comparing right and left at the same time. So with that, I'll ask you, using my ulnar surface of my hands, to keep repeating 99, 99.
99, 99, 99, 99, 99, 99, 99, 99.
Good. So using the ulnar surface of my hand, I checked for tactile fremitus. You could also use the dorsal surface of your hands to check for tactile fremitus, or you could use the balls of your hands to check for tactile fremitus. Certainly you should check in 3 areas posteriorly and 1 area laterally. If you were to find that one side is decreased or absent during this part of the examination, you would concentrate the rest of your examination on that part of the lung fields. Next, we're going to focus on percussion. Remember that this is a difficult technique, but hopefully you've learned to master it since the thorax video. Again, the act of percussion, you place your index or middle finger on the patient's posterior chest, and with your other index or middle finger, strike quickly 2 or 3 times. You want to, of course, begin at the top of the lung fields and move inferiorly. Again, you start at the top, and you always compare side to side, right to left, left to right at each level. It would be an error to go straight down and percuss on one side, then start to percuss on the other side from the top to bottom. It would also be wrong to start at the bottom and to work your way up as you percuss. Remember, percussion must be done on skin and not over a gown or article of clothing. And again, you need the room to be quiet so you can hear these different pitches. Let me demonstrate the technique one more time for you. Good. The next part of the pulmonary examination that we'll demonstrate is the technique of auscultation. For auscultation, you're going to also start at the top of the lungs and also compare side to side as you auscultate. You also use the diaphragm of your stethoscope rather than the bell. Again, use the diaphragm of your stethoscope to auscultate. When you auscultate, you're listening for breath sounds, and breath sounds are normally located at specific locations. Vesicular breath sounds are heard over most of the lung fields, peripherally. They are soft and low-pitched, and inspiration is longer than expiration. Bronchial breath sounds are heard best over the manubrium. They are loud and high-pitched, and expiration lasts longer than inspiration. Tracheal breath sounds are best heard over the trachea in the neck. They're very loud and harsh, and inspiration equals expiration. Bronchovesicular breath sounds are best heard between the scapula, especially on the right side. They're intermediate in both volume and pitch, and the length of inspiration equals the length of expiration. Again, when you auscultate the lungs, you'll ask the patient to grab their shoulders, again to move the scapula laterally to increase the area of lung fields as you can auscultate. The patient will have his mouth open and breathe normally initially. Take some slow breaths, Thad. It's very important to keep your stethoscope on the chest wall during the entire respiratory cycle. The patient needs to complete an entire inspiratory and expiration cycle. When expiration is complete, move your stethoscope quickly to the opposite side. If you are not able to hear breath sounds adequately when you begin, ask the patient to take somewhat deeper breaths. I can also refer you to Dr. Chandrasekhar's physical exam on the lumen to hear examples of bronchial, bronchovesicular, and other breath sounds. If you did hear abnormalities in a specific area of your auscultation, you can also check for transmitted breath sounds over the same area. For example, I would expect to hear vesicular breath sounds in this area. If I heard bronchial breath sounds instead, that would be abnormal. And this time there's 3 maneuvers I can listen for. So with my stethoscope over the area where I heard an abnormality, I'll first ask that to just repeat 99,
99, 99, 99, 99, 99, 99, 99.
As you move your stethoscope to different regions, in a normal lung, 99 is muffled and indistinct, but in a consolidated or airless lung, the 99 becomes loud and clear. The next maneuver is to listen for whispered pectoriloquy. So again, I'm going to listen in the area where I heard the abnormality, and this time I'm going to ask you just to whisper 99 over and over. Again, in normal lung, this is heard very faintly and indistinct, but in a consolidated or airless lung, 99 is heard loud and clear, and we then say that the patient has whispered pectoriloquy. The last transmitted sound to check for, I'm going to ask Thad to just kind of say in a high-pitched voice, E, and I'm going to listen over that same area. So you can say E, E, E. Good. In normal lung tissue, the E sound is faint and somewhat indistinct, but again, in an airless or consolidated lung, the E sound changes and sounds more like an a nasal A sound. This change of sound from E to A is called egophony. There are also extra sounds that you may want to be aware of. We call these sounds adventitial sounds. By that we mean that they're added or extra breath sounds, and you normally would not hear those in a lung examination. These adventitial sounds can either be discontinuous or intermittent, in which case we call them crackles, or they can be continuous. If they're relatively high-pitched, they're known as a wheeze. If they're relatively low-pitched, we call them a rhonchi. Sometimes rhonchis can clear if you ask the patient to cough and then repeat the examination and listen in the same area. Oftentimes, an asthmatic who's having an acute attack will demonstrate findings of wheezing. Again, I'd just like to remind you of a few key points whenever you do the pulmonary exam. Number one, the examination is always done on skin. It's never done over an article of clothing or a gown. Number two, it helps to have the patient grab their shoulders to move their scapula laterally to increase the examinable area of the lung fields. Number three, we always use the diaphragm of our stethoscope when we're doing the pulmonary examination. The room, of course, must be quiet. There can't be extraneous noise from the TV or visitors or guests in the room. If the TV is too loud, turn it off or ask visitors to leave so you can do an adequate lung exam. Again, ask the patient to breathe through their mouth and just to breathe normally initially. But if you're unable to hear the breath sounds, then ask them to take deeper breaths as you listen and auscultate the lung fields. And again, remember, don't move your stethoscope too quickly from one side to the other. Let the patient go through a complete respiratory cycle before you move your stethoscope. The common mistake would be that students move before the patient's completely finished exhalation. And again, always compare right to left at any given level, and start at the top of the lung fields. Remember to perform all the steps of the lung exam: inspection, palpation, percussion, and auscultation on the entire chest. This means anteriorly, laterally, and posteriorly. If you only do the steps posteriorly, you will mostly hear the left and right lower lung sounds. You will miss the right middle lobe completely if you only listen posteriorly. Finally, remember to check for trachea position when in front of the patient. I can refer you back to the thorax video if you need to review this step. I hope you found this video to be helpful in demonstrating the steps of the lung examination. We will now go to the examination rooms in the Clinical Skills Center and practice on each other doing these steps under the guidance of a senior medical student. Good luck.